morning, everyone. Thanks so much. I'm really thrilled to be here to welcome you to Southwest Florida. Our facilities are a county north of us in Lee County. We are a public health system. So we're a not-for-profit public system governed by an elected board. And what makes us unique as a public system is that we don't have any taxing authority. So we operate strictly on patient revenue, as most of your facilities do. So it's a little bit different. We are actually the third largest public system in the country, behind New York hospitals and LA County. We're 1,400 beds, $1.8 billion in revenue. We've got a lot of senior citizens down here, and so we take care of a lot of those folks. And I'm thrilled that you're going to be visiting our Coconut Point facility. I think you'll really enjoy seeing kind of the new and innovative things we're doing there. So this morning I thought we'd spend some time talking not about facilities or construction or anything like that, but about the trends that are affecting healthcare that all of us are facing as we move forward. And I'll let you connect the dots on how it interfaces with your world in the world of facilities, because there's clearly a connection there as these changes occur. So we're going to focus on 5 key trends: the payer market, the care delivery system, consumerism and the growth of consumerism, the competitive environment, and consolidation and scale. And then we'll spend a few minutes on implications for health systems. We're seeing great transformation in the payer markets. If you look at this map, you'll see that the largest insurer in each market holds more than 60% market share in 25 states and more than 50% share in 33 states. And you can see there's some states where they're holding 72 to 93% of the market. And of course, that affects how everybody operates as a healthcare delivery system. The other thing we're seeing that is also contributing to the rise in consumerism is the rise in high deductible plans. If you look back in 2010, about 25% of folks were on high deductible plans, and now 2017, that number's just about 43%. And certainly that contributes to patients and their families shopping for services. The Kaiser study just came out last week, and the average family health plan now is at $19,000 a year is the cost to a family. And at that $19,000, as I said, 43% of those are high deductible plans. So costs continue to rise faster than inflation. Government payers are also increasing as a share of total revenue. You can see that on the commercial side back in 2006, about 38%, and now that's down to 32%, with the government payers increasing up to 62%. And that number is actually a little bit low for this community, which has a very high Medicare population. As you can imagine, our commercial rate is probably in the mid-20s, and our government rate is much higher than that. We're also seeing payers getting tough on high hospital prices. For many years, we've looked at the cost of healthcare in the states and attributed a lot of it to overutilization. And the recent studies that have been coming out is showing that it's not as much overutilization as just simply high prices. We just charge more for things that other countries charge less for. So we know that Anthem is no longer paying for ambulatory MRIs and CTs performed in hospitals without pre-authorization. They're denying claims for non-emergent services and EDs. And we know that CMS is reducing payment for outpatient services provided in hospitals and off-campus outpatient departments. And this is just the beginning of an attempt to get those costs lower and lower. We are all seeing a shift from volume to value, but it's very unpredictable, and it's not consistent throughout the country, and it's really determined by market forces. Everybody's markets are a little bit different, so the speed to value is very fast in some areas and slower in some other areas. We know that CMS has a goal of 50% of Medicare payments being value-based, and private payers also are setting value targets for the coming years. But it's been a slow, sort of an unpredictable process. There's some newer models emerging too, provider service networks or provider-sponsored health plans, and also direct contracting with employers. And these are very, very early in infancy. Provider-sponsored plans have had mixed successes, and it's not an easy thing to do. If you're in the healthcare delivery business, the insurance business is a different ballgame. And if you don't build the expertise or buy the expertise, many systems have lost their shirts trying to get into this. It seems like a relatively easy thing to do, but it is not. It is difficult. And you can see the data there. Direct contracting is something that a lot of employers are interested in. We get asked frequently by our largest employers in our community, can we just do a deal with you and contract with you? But again, it's building that expertise to be able to manage the claims, manage the care, and do that longitudinally. So there's some that are interested, and you can see 3% of employers are direct contracting, 26% are considering it. It says only 26%, but I think 26% is a significant number. When you think about a quarter of companies are saying, hey, we want to do a deal with our local health system. We know that care delivery is changing dramatically too. Over the decades, we have built a system and a whole entire chassis designed to deliver volume care. More surgeries, more admissions, more tests. That's how we survive. And a delivery system designed to deliver longitudinal care is very, very different. And the concept of population health, I'm sure you've talked about, it's a completely different delivery model. And we're having to turn ourselves on our head to do that. And it is not an easy or a quick fix. Of course, we start with physicians, and the world of physicians is changing dramatically. We're seeing a lot of our over 60 physicians are going to be in retirement quite soon. We know that women are making up the majority of young physicians right now. And more than a quarter of physicians are working in practices owned in whole or part by a hospital. And only 16% of physicians are in solo practice nowadays. So the physician world is changing dramatically. For the first time, the majority of physicians do not have an ownership interest in their practice. So the cottage industry that we've all known for decades is changing, and is changing very, very rapidly. The change in reimbursement is also affecting physicians in that many physicians now are being paid not strictly based on volume, but on value. And that's a difficult transition. And it's been a slow transition. If you look at our hospitals, for instance, and our health system, as we've evolved towards some value-based payments, our physicians are kind of lagging behind. And we face that struggle of being judged based on our value, but yet we're paying our physicians based on volume, and we've got to gradually transition that. We tried that this past year, and we practically had a revolt from our physicians when we asked to include a 10% adjustment for quality in their comp. It was quite a battle. So we compromised at 5%, and we're hoping that over time we could increase that and bring them along. And it's really about helping them understand that they can succeed in a value-based world. It's just different, and that's the challenge that we all face. And we know the growth of non-physician providers and extenders is going to be a critical part as we face physician shortages in the future. We'll talk a little bit about precision medicine, and of course, artificial intelligence has been interesting to watch over these past few years, and some of the work that's been done. The FDA has approved some AI applications in the areas of radiology, et cetera. So we're going to see more and more of that moving forward. Talked about precision medicine a little bit. You know, as historically we've treated patients basically the same. If you came in for a particular illness, you got the same medicine as the person next to you with the same illness. And now there's beginning to use genomics to try to identify which medicines would actually work best for particular physicians. Probably most prevalent in cancer therapies, but it's going to be more widespread as we develop more of these technologies. The concept of digital care, of course, is something that will grow with time. It's estimated that about 1/3 of ambulatory visits could be addressed through telehealth, and 80% of behavioral visits could be addressed through telehealth. And the telehealth companies are just waiting to grow, and the money is pouring into them in Silicon Valley. We haven't even seen the technologies that we're going to see in the future. Those of you who may experience or have experienced irregular heart rates, I don't know if you're familiar with the Cardia app on Apple. It's a free app. So if you were sitting here today and you felt that your heart was fluttering and something didn't feel right, you would step out, you call your cardiologist, and they tell you to come by next week when you got home. And by the time you got home, it would probably revert to normal. So they put a Holter monitor on you, they'd monitor you for a week or two, and maybe it would show up and maybe it wouldn't. If this were to happen today with Kardia, you download a free app on Apple, Kardia. You buy this little device for $99. It sticks on the back of your phone, and as you're sitting there, you would just put your fingers on it, and it records a medical-grade EKG that you can immediately email to your physician, who will tell you, yes, you're an AFib, do A, B, C, or D. Now, you can imagine the difference in cost, right? The scenario that I just described before is a $3,000 to $5,000 scenario, and this was a $99 application. So when health systems are at risk for the dollar, we're going to be giving these away, okay? Because it's going to save tons of money. So it works great for the patients. It works great for the payers. Not so great for the docs in a fee-for-service world, right? So again, those are the types of discussions you need to have with docs to say, hey, this can work. We just need to be thinking about things differently. And as health systems go at risk in the future, you're going to see technologies like that exploding. There are going to be so many different things that we can do that we've never even imagined. We know social determinants play a critical role. What is the most important number in assessing your health status? It is not your blood pressure. It is not your cholesterol. It is not your BMI. It is your zip code. That's what determines most likely and our ability to predict how well you're going to do with your health. And we know it relates to all these things: education, food, social context, et cetera. And again, as health systems go at risk for the healthcare dollar, these suddenly become very important. We now are providing food for patients after discharge, transportation to make sure they get to their visits. All these things are going to be part of our role as healthcare professionals. We know there's a major problem with behavioral health. We face this in the state of Florida especially. I think we are the worst, second to worst state in the nation. And this region is probably the second or third worst in the state for behavioral health funding. It is really a tragedy. And we know that so many patients are showing up on our EDs with behavioral health challenges. And they require more resources. We're facing this here, and we are bringing all the providers of behavioral health services together in a consortium to try to figure out how do we solve this problem locally, because it will continue to be an issue. And I think telehealth is going to play a big role in this, in our ability to utilize those resources. The third piece of the puzzle is this concept of consumerism. We talked earlier about how patients are having to come out of pocket much more than ever before. And as a result, with high deductible plans, et cetera, they are looking around and they are shopping around. And there are a lot of forces, as I said. We've got the upper left, the shifting cost to consumers. On the lower left, something that kind of snuck up on us is now millennials are a larger cohort than boomers. And they think differently, they act differently, and their expectations are quite different as it relates to what they expect from healthcare. And it's been primed, excuse the pun, by Amazon and other services that they are used to. Uber, reducing friction from the commercial space, and as a result, they expect that same type of service as it relates to healthcare. Millennials, as I said, look at things differently. The majority want to book appointments with mobile apps. They would prefer to see a doctor virtually. Now think about that compared to our parents and that shift in just a couple of generations. It's pretty dramatic. 3/4 will look at online reviews. 1/3 have downloaded a health app in the last 30 days. And 42% have used synchronous video telemedicine. So again, this is something they're quite comfortable with and something that we're going to need to expand and think about how that affects all of you in the facilities world. But of course, hospitals are still lagging behind. Only 14% offer digital tools and information, 23% offer telehealth, 20% have an online price estimation tool. That's pretty remarkable when you think about the rise of consumer, that only 1 in 5 health systems you could actually go to and say, what is this going to cost me? And the issue of messaging and communication, one of the biggest challenges we face and have faced historically is communication. I was talking to a group the other day, and I was describing what it was like when I came into practice back in 1983, and I said, believe it or not, physicians actually talked to each other back then. We would meet in the doctor's lounge and we would discuss cases, and if we needed some help, we would ask for it and say, would you mind seeing this patient later on in the day? And now we're talking through machines, or we're talking through third parties, which is really a terrible way to do it. Putting nurses in the middle of conversations just doesn't really work well for patients. So we're trying to build capabilities within our system so we can actually get communication restored in a healthy way that benefits patients, because that's really what this is all about. So we know that consumerism is growing rapidly. There's been an increased focus, but there's still a significant gap in what consumers want and what we realize they need compared to our capability to deliver that. The concept of 24/7 on-demand access, as much as we are a 24/7 business, we all know that things are different on the weekend. Things just don't get done as efficiently as they should and as they do during the week. A pricing strategy is really important. As health systems move forward, we have got to figure out a way to be price transparent and to be price competitive. One of the challenges that we face as a large system is in our outpatient services, trying to be competitive with the freestanding centers. We have a majority of the hospital beds in our county. We have 95% of the hospital beds, but there are 30 physician-owned surgery centers in our county. So someone said, yeah, you've got a monopoly, but you've got a monopoly on the black and white TV market. You got the stuff that nobody wants, and all the profitable stuff is owned by others in the community. So mentioning the gaps again, if you look at healthcare provider priorities and capabilities, this is a busy slide, but if you could just see that where the priority is compared to the capabilities on improving consumer experience, offering variety of options, digital tools, virtual access points, using consumer learning, outpatient pricing strategy. That's dramatic, that gap right there. And then, of course, the issue of price transparency. We all see it as a need and a priority, but there are significant gaps in our ability to deliver that type of care. So you can classify health systems into 4 different categories, and only 8% are in Tier 1, which are early adopters with a clear vision of the future, who have dedicated significant resources to being leaders in the consumer realm. And look at the Tier 3 and Tier 4, where most of us are living right now. And it's going to take us some time to change our focus. We talk about being patient-centered. You hear those words thrown about all the time. We're a patient-centered system. The fact of the matter is that the vast majority of our health systems are provider-centered. We center our work around our provider, around our doctors, our nurses, our technicians. They're not patient-centered at all. And until we really begin to view this as a patient-centered process and a family-centered process, it's going to be difficult for us to move up to Tier 1. So the issue is, how do you grow? How do you retain customers? Fixing the front door, which of course is access, repositioning shoppable services, which is pricing, and then of course, a positive experience for patients, retaining customers and building loyalty. And it's really about building loyalty, because most of us do pretty well in the patient experience realm, in that if you look at the HCAHPS scores from 0 to 10, most of us are going to be over 7, 8, 9, and 10. The challenge is with top box scoring, you're only getting credit for 9s and 10s. So we see that challenge on a daily basis. And how do you go from an 8 to a 9? How do you push that to get to that top box? And that's about building loyalty. Patients are happy, they like us, they just don't love us. And that's really where we all need to get. We've got to get to that point of where patients just love us and they want to tell their friends about any type of system. Leadership, branding, insights, analytics, and digital strategy. That's what's going to drive this consumer move. So again, these are some of the things. It's a busy slide. I won't go through it. These slides are all available. If anybody wants them, I can forward them to you. But it talks about some things that we can do in the near future, and down the road to improve access, pricing, experience, and foundation. So we're seeing new competitors in the ecosystem, and it's you only have to pick up the Wall Street Journal on any given day and see the latest mega merger that's affecting healthcare. And it's interesting when you start looking at the numbers of these companies and the dollar capitalization that they have, that you realize that this is a real issue. This is not something that is just going to be on the fringes. This is going to be quite significant. If you look at the Cigna Express Scripts merger, March 7th, they announced that they were buying the pharmacy benefits manager, Express Scripts, combined revenue $140 billion. That's big, those are big numbers. The United Optum situation, $201 billion. Optum really is the leader in data and data management. United Healthcare is buying physician groups, buying DaVita, Surgical Care Affiliates, which is an outpatient surgery center business. They're conglomerating all sorts of delivery models and buying the ones that they feel will be the most profitable, right? The outpatient world, the post-acute world. You don't see them buying too many hospitals or acute care facilities. CVS, Aetna, $246 billion organization, 9,700 stores, 1,100 clinics. They're going to expand retail health, enhance pharmacy benefits, and CVS stores are going to become health centers. This is their plan, and this is the model that they're using. And you take a next step up to the Walmart Humana thing. They're reportedly in talks. That would be a $540 billion organization. And just imagine what that could do to our communities and what it might mean to us in the incumbent world in healthcare. Because in healthcare, we've got the incumbents, we've got progressives, and we've got disruptors. So the CVS Aetna strategy is an interesting one because in their words, this transaction creates opportunity to rethink and reinvent U.S. healthcare. An innovative new healthcare platform, easier to use, less expensive, integrated broadly within the marketplace to deliver superior coordinated care. And if we're not careful, we're going to be left off the bus if we don't begin to do exactly what they're describing at CVS. We start in stores, home health, digital tools, data, and advanced analytics. This is what they're bringing to the game. We know that Apple now is launching medical clinics for employees. They're exploring acquiring medical clinic companies, and there's a lot going on in Apple that they haven't revealed yet. They do want to get into the healthcare business in a big way. And you know, when Apple does something, they do it in a big way, and they usually do it right. Amazon has purchased a pharmacy company. They've licensed for wholesale pharmacy in 12 states, and they're also looking at a lot of other things in healthcare. I was at the Florida Hospital Association meeting last month, and a representative from Amazon was there. He said they started a whole division just related to healthcare and how they're going to get into the space. We've all heard about the Amazon Berkshire JP Morgan initiative led by Atul Gawande. Most of you know Dr. Gawande is a surgeon from Boston. He's written a lot of seminal books on healthcare, and they announced him as president of this organization. Warren Buffett has said the ballooning costs of healthcare act as a hungry tapeworm on the American economy. We're not coming with answers, but we do not accept it as inevitable. So they're acknowledging they don't have the answers, but they're going to find them, and they're going to work real hard to get to them. So this is going to be an interesting process, is what are they going to come up with? How will it benefit or threaten the rest of us in the healthcare space? And we're seeing new competitors all over the place. If you look in the Minute Clinic, the Doctor on Demand, all these companies that are being funded by venture capitalists. As I said, money is pouring into these companies because people see the tremendous opportunity in the ability to get information, to challenge the current delivery system. And these are the disruptors that are going to change what healthcare looks like. And I can tell you with a lot of confidence that healthcare is going to look very different in 5 years. We're not going to recognize the traditional things that we've seen for decades and decades. And the last trend we'll talk about is consolidation and scale. And we're seeing tremendous consolidation in the healthcare space. If you look at the number of merger and acquisition transactions starting in 2009, there's been a steady increase. And they've almost doubled in that 10-year period from 2007 to 2017. 11 of the transactions in 2017 involved organizations with more than $1 billion in revenue. So these are big systems, big organizations getting together for scale. There's been a lot of mergers of equals, Catholic Health Initiatives and Dignity Health, Advocate and Aurora Mercy, and Bon Secours, anywhere from $8 billion to $28 billion annual revenue. 140 hospitals, 27 hospitals, 43 hospitals. The announcement was just made in Texas with Herman and Baylor White Scott coming together, beginning talks. They signed a letter of intent. That would be a 68 hospital system in Texas. So this work continues. So why are health systems coming together like this, expanding geographic reach, adding competencies, looking for matches, enhancing brand and reputation, driving efficiencies, building negotiation leverage, and improving access to capital? Of course, the challenge that we face and what you're hearing from the government is, are these going to be anti-competitive moves? Are they going to raise prices rather than lower prices? And so this is the dynamic that's going on throughout the country. It's that battle between pricing, patient choice, and the need for scale as systems are growing. What's interesting to look at is if you look at some of these mergers and you look at CHI and Dignity coming together at $29 billion, and you even look at a giant like HCA at $44 billion, it is dwarfed by these other mergers that we talked about, $201 billion, $246, $540 billion, Amazon at $178 billion. So there's just an order of magnitude between our traditional players. Even as they get together, they still are not even close to what's happening on the other side, in the corporate world, and the change that could have on healthcare. So what does that mean for us as health system and providers of healthcare, the so-called incumbents? How are we going to compete with these type of initiatives that are going on? And there's four, in my mind, four basic things we need to do, and I think it's mirrored by the internet economy, is perfect your product, get serious about costs, remove friction, and control the last mile. So you're looking at excellent health outcomes, financial viability, coordinated care, and patient experience. And those are basically our four strategic initiatives, and they line up nicely with this analysis of what will be required. So what does Amazon, Apple, Facebook, and Google do? They work continuously to perfect their products, and they have the market share to match. When Steve Jobs was asked, what product are you most proud of? He said, what I'm most proud of is of the things we decided not to do, because that allowed us to focus on the few things we can do excellently. And I think that's another situation that we face as healthcare providers, is getting focused to say, what are the must-do, can't fails? There's a lot of great things out there. There's a lot of great ideas, but we need to get focused on these few things and do them really well and perfect that product. So again, identify areas of competitive differentiation, perfect them, and consider those areas in relationship to new innovative entrants and national competitors. Tim Cook said, healthcare hasn't been constructed in a way where the focus is making great products. The focus has been on making products that can get reimbursed through the insurance companies, through Medicare, through Medicaid. And that's really true, right? That's how we've designed our systems and designed what we bring to the table. And what Tim Cook is saying is, no, that's not the focus. That's not what you should be looking at. We need to change how we view healthcare delivery. I mentioned the challenge with costs. The big four, as we call them, Amazon, Apple, Facebook, and Google, relentlessly pursue the lowest possible cost. We know healthcare spending is 18% of GDP. Insurance premiums have gone up 134% for employers and 167% for workers in the past 15 years. I mentioned that the average family plan now is over $19,000. So the new healthcare delivery will need to develop a platform that's more affordable. If you look at growth rate for operating revenue and operating expenses, that's not an attractive graph because our expenses can continue to go up as health systems, but our revenues are not matching up. And so we're seeing a significant pinching of margins, and we're seeing it throughout the system. Removing friction. This is something that those four do extremely well. They remove even the minor inconveniences, fewer clicks, faster search results, better interfaces, easier payments, faster delivery. And we have all sorts of friction in our system. Anybody who's interfaced with any health system knows the frustration, especially if you've got different medical records for different providers, you're telling your story multiple times, getting appointments. I mean, it's just a nightmare for patients. And we need to model some of the things that these companies are doing to attack these sources of friction, whether it's scheduling, communication, wayfinding. There's so many things that are going to be out there that are going to help us through that. But less friction means consumer loyalty. Jeff Bezos, people have a voracious appetite for a better way, and yesterday's wow quickly becomes today's ordinary. You cannot rest on your laurels in this world. Customers won't have it. And that's so true. Look at what we've experienced just in our lifetimes in the technologies world. I mean, a Walkman was like the coolest thing in the world, and you know, it's, come on. That's the ordinary now, isn't it? Controlling the last mile, and that's really about the patient experience, and who does that better than Amazon and Uber, right? I mean, they've created $600 billion in market value by discovering and perfecting that concept. They take experience that consumers don't even perceive as a problem, shopping, hailing a cab, and they transform themselves into actionable, appealing, and engaging. And they're never satisfied with the level of convenience and the engagement of consumers. Has anybody used Uber in the room? It's a pretty amazing concept, and it is so frictionless for the most part. And that's the concept of controlling that last mile. So, last mile implications for healthcare. Healthcare's last mile is the least convenient and least appealing of any industry. And that's our greatest vulnerability. So we have got to find a way to make that last mile not a chore, but an experience, and not frustrating, but engaging. So Atul Gawande said, better is possible. It does not take genius, it takes diligence, it takes moral clarity, it takes ingenuity, and above all, it takes a willingness to try it. So whether we are willing to try it or not, we are going to be forced to try it if we want to stay in the healthcare business. So it's something that we will all have to do. We will have to do those four things if we are going to succeed in a very new healthcare environment in the future. And those changes do have significant implications for all of you as facility experts. And I think you need to be thinking about that in your organizations, how this will all work together. So with that, I want to thank you. We've got about 6 minutes for any type of questions you might have. I appreciate you having me here today. I thoroughly enjoyed it, and again, wanted to welcome you to Southwest Florida. I'm really excited that you're going to come and view our Coconut Point facility. I think you'll really enjoy seeing it. So thank you.
Thank you very much. This was an excellent presentation. Really appreciate it. I know we have a few questions, but I have one question for you. The quote from Steve Jobs on deciding what not to do is more important than deciding what to do. And for the past, yesterday we talked a lot about, moving into retail, as you shared this slide with CVS. When you look out for the next decade, everybody's trying to get into retail, home care. Are there certain areas that you think, and maybe you don't want to answer this question, but maybe healthcare should maybe decide not to go into?
Well, I think the areas that you mentioned are areas that have to be served. Yeah. I think the question is, are we best doing it as a health system? For instance, for our health system as a single health system in Southwest Florida, are those businesses the ones that we want to be in, or do we want to partner with someone else? I think sometimes we have the tendency that we've got to own everything, we've got to have everything, but if you can have good, solid relationships with others to provide those services, it's really about building a system of care and not necessarily having to own. Because there are things that we may not do as well as others. And to think that we can do everything as well as someone who's been doing it exclusively is a fallacy. Yeah.
A great presentation. A question for you on the patient-centered experience. It almost seems to me like we need to drop the name patient and go back to consumer-focused. So one thought with that is when I think about electronic health records. So right now it's very siloed with the Cerners, et cetera, systems that are out there today. And as I hear and see, you've really got to have the ability for this consumer-based individual to have their data, their information, they own it, and they decide who they share it with. So I'm curious where you see that going in the future, and who do you think might be the leaders if that's going to be the direction things go?
Yeah, we went to an Epic enterprise system a number of years ago. How many systems are on Epic? Wow, yeah, they're clearly becoming the dominant player in the country. And so anywhere in our system, our mantra is one patient, one record. So whether you go to one of our laboratories, one of our outpatient facilities, one of our physicians, in our hospital, in our ED, you have a single medical record there. And I think that's an enterprise record is going to be key. Now, that doesn't solve the problem of interoperability among providers in the community. What's interesting is as we began to talk to providers in the community, many of them were skittish about getting on a record with us because frankly, they didn't trust the hospital system. You know, there is a little distrust from independent physicians in hospital systems. So as a result, that was a challenge. But I think that type of collaboration, consolidation, interoperability is really going to make the difference as we move forward.
Question here.
For your population that's older than average, you talked about millennials using technology. Are you finding the folks that are a little bit past millennial that are adopting more and more technology and being willing to use that, where you may transition into an earlier adopter, even though you have a population that's not necessarily millennial driven?
Yeah, that's a great question. What we're seeing actually is that our older patients are embracing a lot of these technologies as long as you do it in a way that provides comfort to them. If you teach them how to do it, if you show them how to do it, they see the benefit of it. Obviously, our millennials are growing up with this, and it's like tying their shoes. But in our home health programs and a lot of our programs, we're using these technologies, and our older folks are actually they're tapping into it because many of them actually are using it in dealing with their grandkids in Ohio. You know, they're FaceTiming and they're doing all this stuff. So you can't overcomplicate it. You know, if you can find a program for them that they can easily turn on, that doesn't have a lot of bells and whistles, and you can simplify it, they'll utilize it. Yeah.
Quick question on the accountable care organizations. Considering this big change in the business and competition coming with Amazon and so forth, do you see the accountable care organizations still being the model of the future for healthcare systems? And is that still relevant considering the competition?
Yeah, the question on accountable care organizations, I think you have to take that term with a grain of salt, okay? Whether we call them ACOs or PSNs or something else, it's really about accountability, okay? And being accountable for the patient over a population. So I believe that is going to be the model for most of health systems moving forward, is the ability to say, I am responsible for your care. And I'm going to do everything I can to keep you out of the hospital, keep you out of the ED, keep you out of surgery, make sure you get the medicines you need and the appointments you need when you get them. I think that's a winner, regardless of what title and what letters are on it. It's really the model of care that's most important. And the government will come up with all sorts of different plans, you know, shared savings plans and ACOs and next generation ACOs, et cetera. But it's that basic chassis is really what we need to focus on.
I want to thank you so much for joining us this morning.
Thank you. Thanks.